Good evening, everyone. I would like to thank each and everyone being part of this webinar tonight. We started slightly late, 4 minutes late, but everyone was still entering. I think everyone entered slightly lately, but I think we need to start, and as the webinar continues, then we can actually just let anyone else in. So welcome to this night's webinar. Like I said, I would like to welcome each and everyone. This is really, I think, quite an impressive hot topic that we need to discuss tonight, because I think it's appropriate to where we are currently in the management of head and neck cancers. We are privileged to have quite a jam-packed panel tonight, and I'm quickly going to introduce each and everyone as we go along. Please just be so kind, all the panelists, to put on your video cameras so that everyone can see you. With no further ado, I think we must start first with Professor Robert Haddad. Prof. Haddad, good evening. Welcome to this night's webinar. Welcome to South Africa. In short, Professor Haddad, Professor of Medicine, Harvard Medical School. He's the Division Chief and Institute Physician, Center of Head and Neck Oncology Program. He's also a member of the Department of Adult Oncology at the Dana-Farber Cancer Institute in Boston. And Prof. Haddad is going to share his knowledge tonight on the advances that we have in immunotherapy and where we are at the moment. Our second international speaker tonight is Professor Mark Zafariu. Good evening, Prof. Welcome to this webinar as well. Professor Zafariu, Professor at the Department of Head and Neck Surgery, Division of Surgery at the University of Texas, MD Anderson Cancer Center in Houston. He's also the Section Chief, Head and Neck Endocrine Surgery, like I said, the University of Texas at MD Anderson. Good evening, Prof. Welcome, as I said. Then, if we look at the local panelists tonight, we really have a good representation from the whole South Africa. I would like to welcome Dr. Julie Vetter. Dr. Vetter is a radiation and clinical oncologist working in state practice for approximately more than 17 years in Groote Schuur Hospital, University of Cape Town, or UCT. Special interest in cancers of the head and neck, eyes and skin, non-melanomas. And she also has a special interest in brachytherapy in head and neck and eye tumors. Good evening, Dr. Julie Vetter. And like I said, thank you very much for attending tonight and being part of the panel. Then Dr. Karen Foster. Dr. Karen Foster is a clinical oncologist and head of the clinical unit at the Department of Oncology, University of Free State, Universitas Hospital in Bloemfontein. Good evening, Dr. Foster. Welcome once again, and thank you for attending. Then if we have a look at Dr. Andre Vos. Dr. Andre Vos is a clinical and radiation oncologist. He's practicing in Panorama in Cape Town. He completed his undergraduate studies at the University of Stellenbosch, and then he completed his residency at radiation oncology also at UCT. And he obtained a clinical fellowship from the University of Toronto in 2020, after which he returned to South Africa and he joined the Panorama Center for Surgical Oncology. He's also involved with the Department of Radiation Oncology at the University of Stellenbosch as a visiting consultant. Then Dr. Richard Kanile. Good evening, Dr. Kanile. Thank you very much for joining us as well. He is currently the head of department at medical oncology at Steve Biko Academical Hospital in Pretoria, South Africa, and he's working as a part-time consultant at the Mary Potter Oncology Private Center. He's a medical oncologist. Good evening, Dr. Kanile. And then Dr. Brent Green. Dr. Green qualified as a clinical oncologist in 2010. He's been a oncologist in private practice since then in Bloemfontein in the Free State. And he also got a special interest in head and neck cancer specific and the management of cancer. So welcome, everyone. Welcome to this meeting tonight. I quickly want to just also take a short time to just thank our sponsors. Our sponsors tonight, this wouldn't have been possible without you. I want to thank MSD Oncology specifically, and I want to specifically mention two people. Nikki Bruder. Nikki, thank you very much. She's currently Oncology Business Unit Director in South Africa. And then Mr. Bernice Depree, Oncology Brand and Customer Manager. I really want to thank you guys. Like I said, you really made this webinar possible tonight. Just have a look also on the screen. There's a QR code. This QR code will take you directly to the MSD website and all the indications. And currently for registration of pembrolizumab in South Africa can be found on the website. And then just the last slide quickly before we start. This is just another upcoming webinar soon. That the date will be advertised within the next week or two. This is an upcoming webinar as part of the South African Head and Neck Oncological Society. Emphasis placed in this webinar on reconstruction and head and neck cancer, specifically on intraoral defects. And I mean, we are privileged to have again two amazing international speakers, Professor Matthew Anasona from MD Anderson and Dr. Kongri Chaizati. So before no further ado, I think we must kick off. Professor Haddad, you are first in line, so thank you very much once again for your attendance tonight and being willing to share your knowledge. I must say you had a difficult week. I know you went to Ireland and back, and I think you must be tired. But thank you very much for willingness to enlighten us tonight. Thank you very much. Welcome.
Thank you so much, Dr. Kluge. It's really a pleasure and an honor to join all of you on the panel, and my colleague also, Dr. Zafereyo from Houston. Hopefully, I was telling Johan before, hopefully we get to do this in person next time, and I get to meet everyone in person. I was asked to talk about immunotherapy in head and neck cancer, so I'm going to share my screen. And after speaking to Johan last week, he wanted me to focus my talk on the recurrent metastatic head and neck cancer setting, where obviously we have where we have seen a lot of advance in how we use checkpoint inhibitors in recurrent metastatic disease. And I wanted to talk a little bit about some of the really looking forward in terms of what happens now in the next 5 to 10 years in terms of pipeline. What type of drugs and interventions within the immunotherapy world do we expect to see, and talk about some of the biomarker work we have done on some of these large phase 3 trials. I'm going to start. So I'm going to start with my disclosures. So I work with a lot of companies on drug development and pipeline, and I chair the NCCN Thyroid Committee and member of the Head and Neck NCCN Guidelines Committee. So obviously, this is a quick summary of how we treat head and neck cancer in 2023. We obviously, it's one of the cancers where multidisciplinary care is really important from early on. We interact very closely with surgical oncology and radiation oncology in managing patients with early stage, intermediate, or advanced stage disease. And obviously for this group, which is quite experienced, I don't have to go through a lot of detail here in terms of combining radiation, chemotherapy, and surgery, and the importance of the multidisciplinary clinic. If I really ask the question, where do we stand today in 2023 in the landscape of recurrent and metastatic head and neck cancer? We have 2 checkpoint inhibitors that currently are available for our patients with recurrent metastatic disease. Those are pembrolizumab and nivolumab. And those agents were approved based on large randomized phase 3 studies listed here: Keynote 48, Keynote 12, and Checkmate 141. The benefit appears to be confined to those patients who have CPS positive disease, combined positive score disease. And that really has become an important part of how we manage patients. One of the first tests we ask for when we are dealing with a recurrent metastatic head and neck cancer setting is we ask for the CPS, which is a fairly straightforward test to do. Every patient should have this test. It gives you a lot of information about really whether immunotherapy by itself would be an appropriate intervention for that patient. The role of the other biomarkers, I'm going to discuss those briefly. Tumor mutational burden, whether it's tissue or blood, and gene expression profile continues to be under evaluation. It has not really made it to the point of being a standard of care approach, but it's something that we and others are very interested in. Now, the response rate to immunotherapy can be in the 20 to 40%, depending on what paper you look at. Duration of response can go from 20 to 30 months. It is really clear in my mind that the impact of immunotherapy on head and neck cancer treatment has been very profound in the past 5 years. These drugs can be really game changers in how we manage patients. We have seen a significant number of really responses, so that 20 to 4% can be durable, can be profound, and even I use the word in quotation here, cure, which is not something I expected I would say about recurrent metastatic head and neck cancer. We've had now a number of patients who go into complete remission and response with single agent checkpoint inhibition. So really, we feel that these agents are very important to have available for our patients with recurrent metastatic disease. Now, obviously, what happens beyond checkpoint inhibition continues to be an area of active investigation. Chemotherapy with or without cetuximab continues to be used there. Cetuximab as a single agent, or obviously clinical trials when and if available. So when we talk about managing patients with recurrent and metastatic head and neck cancer, obviously for some patients there is a re-radiation question which we pursue. Some patients even have a surgical option. So think of someone with laryngeal cancer, has recurrent disease. You still have the option of a laryngectomy for that patient, obviously. So one of the first questions we ask is there a role for surgeries, a role for re-irradiation? Obviously, for most patients, that's not an option. Now we're going into palliative systemic therapy with either immunotherapy by itself or with chemotherapy, again, depending on the CPS score. Sometimes we go to chemotherapy with cetuximab if, for example, the patient has no expression of PD-L1, or more importantly, clinical trials for the appropriate patients. For some patients, obviously, more treatment is not appropriate, and referral for supportive care and hospice care is the right intervention. So let's really talk about the role of immunotherapy and run some of the clinical trials that we have seen in the past, again, 5 to 7 years. The first one that we were involved in, the phase 3 Checkmate 141 study, is really the first phase 3 study to look at the checkpoint inhibitor nivolumab here in comparison to investigator choice chemotherapy. And the choice was between methotrexate, docetaxel, or cetuximab. This was primarily a second-line treatment, meaning most of the patients had received chemotherapy in the first-line recurrent metastatic disease and then proceeded to the second-line nivo or chemo. There were, though, some patients on this trial who had what we call the platinum refractory head and neck cancer, meaning they had recurrent disease within 6 months of completing chemo-RT and were allowed to enroll on this trial. And this is the top-line data here showing an improvement in survival of 2 months with nivolumab compared to chemotherapy with a hazard ratio of 0.7, leading to regulatory approval of nivolumab and the treatment of patients that have platinum refractory or patients with recurrent head and neck cancer that have seen a platinum before. The second trial I wanted to share with you is really one of, I would consider, the most important trials in the past decade in head and neck cancer, and that's the KEYNOTE-048. This is a study that has 3 arms. Again, a study that was performed exclusively in patients with recurrent head and neck cancer being treated in the first-line setting. So the patient have had chemoradiation, they've had 6 months at least of disease-free interval, and then they had recurrent disease. And then they were randomized to either pembrolizumab as a single agent, pembrolizumab with chemotherapy, a platinum 5-FU platform, or what's known as the extreme regimen, cetuximab platinum 5-FU. 1-1-1 randomization, a fairly large trial, 300 patients per arm. More than 80% of the patients had a CPS of 1 or more, and a CPS of 20 was around 40% of patients. And those are important numbers to keep in mind, because for the vast majority of head and neck cancer patients, you will have CPS expression. Around 20% of patients were P16 positive. Now, there were 2 comparisons done on this trial. There was a comparison between pembro chemo compared to the extreme regimen, and then pembro alone compared to the extreme regimen. There was no comparison between the pembro-containing arms on this trial. Looking at the first comparison of pembro as a single agent versus a platinum 5-FU cetuximab, so 1 drug versus 3 drug, what becomes readily visible here and really important is that if your CPS is 20 or more, significant improvement in overall survival with single-agent pembrolizumab, with a hazard ratio of very robust of 0.61, and overall survival median of 14.9 months versus 10.7 months with the extreme regimen. I want you to remember those two numbers for later on. Median OS 14.9, extreme regimen OS 10.7. With CPS more than 1, now the hazard ratio goes up to 0.78, still really showing a benefit of pembro compared to chemo, cetuximab, but unclear if that benefit in that CPS 1 group is primarily driven by the CPS 20 or more group. Hence, the data on the CPS 1 to 19 group becomes very important, and I'm going to show you that later. Now, when we look at the comparison of pembro chemo versus the extreme regimen, again, with the CPS 20, CPS 1, here we are seeing very robust hazard ratio, 0.6, 0.65. Clearly, the pembro chemo is performing better than the extreme regimen here. And even when you look at the total patient population, which obviously would have included those with a CPS 0, you see a benefit of pembro chemo versus the extreme regimen. So what was really unanswered with this data is what happens with that CPS 1 to 19 group. Does that group benefit from pembro as a single agent? So that analysis was done subsequently and published in JCO last year by my friend, Dr. Burtness. And what it really shows here is, number one observation, if your CPS is 0, you should not be using pembrolizumab as a single agent. The overall survival median is 7.9 months, and for the extreme is 11.3. So clearly here, you should use the extreme regimen. But when you look at the CPS 1 to 19, the hazard ratio here is 0.86, and there does not appear to be a difference in those two groups. But that is a question, because if you see that number of hazard ratio of 0.86 with pembro alone, and you look here on the subsequent analysis in the pembro chemo arm, that hazard ratio becomes 0.71. So if you have a CPS of 1 to 19, then you have the option to either give single agent pembro or pembro plus chemo. And the debate here around this question continues to be quite vivid, with many people considering that low hazard ratio of 0.71 is the better way to treat patients with that CPS 1 to 19, meaning to offer chemo plus pembro. In my own practice, when I am having a CPS 1 to 19, and when I have a patient who has a good performance status and low burden of disease, I'm often starting with single agent pembro before I go to full-blown chemotherapy pembrolizumab. But it's an area of active interest and debate in our field. So based on the results of this important trial of the KEYNOTE-048 study, the use of pembro with or without chemo has now become the standard of care for treating patients with recurrent metastatic head and neck cancer in the US, in Europe, and many parts of the world. And these are the conclusions of KEYNOTE-048. Now, recently, we published the results of another large phase 3 study, which obviously we have been waiting on for quite a bit. It's close to 1,000 patient trial known as Checkmate 651, comparing Nivo plus Ipi versus the extreme regimen. So this is a 2-arm study. Again, first-line recurrent metastatic in patients who have had at least 6 months of disease-free interval from their chemoradiation. This was a negative study, unfortunately, and in my opinion, a lot of the reason for that lies in the fact that people on the extreme regimen were able to get immunotherapy as their second-line treatment because immunotherapy had become available. That was not the case with the KEYNOTE-048 study. So when we look at the data of this trial here, for the primary endpoint, overall survival, Nivo plus Ipi versus extreme, we see no difference in the p-value, no difference in the median overall survival, 13.9 versus 13.5, with a p-value of 0.4. I would point out on this slide here that the overall survival of the extreme regimen on this trial was significantly better than we've ever seen with the extreme regimen. So patients on this trial that went on the extreme regimen had a very high overall survival compared to what historically we've seen with the extreme, which was around 10 to 11 months. Now, when you look specifically at the high CPS group, 20 or more, you see a p-value of 0.0469 with a 17.6 months versus 14.6 months on the extreme. Both of those numbers are numerically quite higher than what we have seen with the CPS 20 group on the Keynote-048. Nevertheless, obviously, with this overall negative data on the p-value, this is not a regimen we currently use in treating our patients in that first-line recurrent metastatic setting. But in my opinion, this also study confirms the benefit of immunotherapy in the first-line treatment, because we are seeing very robust overall survival here in that high CPS group. And when I look at the duration of response, you see a number here of 32.6 months, which is a number we've never seen in head and neck cancer recurrent metastatic disease before. So very high duration of response with this combination of nivolumab and ipilimumab. Now, as the medical oncologists on the panel know, many oncologists don't like to use 5-FU in head and neck cancer because you have to put in a port, you have to give continuous infusion. So one of the questions has been whether you can replace 5-FU with paclitaxel. So this is a study that was presented at ESMO last year, known as the B10 study, where instead of giving 5-FU, the study essentially called for using carboplatin paclitaxel with pembrolizumab. This was a 100-patient study, single-arm study, and essentially showed, again, similar patient distribution. Around 40% of the patient had a CPS of 20 or more, 80% had a CPS of 1 or more, and it showed an overall response rate of around 40%, which is similar to the pembro chemo arm on the Keynote-048 study. So essentially what this study did is that it showed that if you, for some reason, do not want to give 5-FU, or you have a situation where you do not have access to putting in a port and you need to start treatment immediately, this will be another regimen you can use that does not require a port, that allows you to give chemotherapy plus immunotherapy. It's actually in the US a regimen that's now commonly used when insurance approves it. Because it's not within FDA label to give carbotaxel pembro, but because we have this data now, we are able now to justify it to many insurers, where instead of giving a platinum 5-FU pembro, we can give carboplatin paclitaxel and pembrolizumab. And these are the responses, again, shown on this. Again, similar data to the Keynote-48, reinforcing the importance of chemoimmunotherapy for some patients. Now, what happens now really when we look beyond checkpoint inhibitor, beyond pembro, beyond nivo, or what happens if you start combining pembro or nivo with other agents? And I'm going to show you that's really 2 or 3 studies here that were recently presented. This is one from my colleague Ezra Cohen from AACR this year, looking at a novel EGFR antibody, also targeting LGR5 in patients who have already been exposed to a checkpoint inhibitor. This study, again, small study, 49 patients, showed an overall response rate of 37%. So the way I look at this data, it's interesting, it's promising. This is an agent that probably will be studied in a larger trial going forward, but essentially showing a signal of better EGFR inhibition than we typically have seen with drugs like cetuximab or afatinib or gefitinib or other agents. Also, as you all know, there has been good interest in combining pembrolizumab with cetuximab. This is data from also San Diego, looking at this combination and showing really quite a robust response, around 45% with the combination of pembro plus cetuximab. Another antibody against EGFR that was recently presented at the ASCO meeting by Dr. Hanna, who works with me here at Dana-Farber. This is a first-line study, recurrent metastatic, adding pembrolizumab to another EGFR inhibitor that also targets TGF. So this is a combination of the BCA-101 with pembro. And what was interesting with this data is that the HPV negative cohort seems to have a much larger benefit with this combination than the HPV positive group. Now, as you all know, with cetuximab, a lot of us, including myself, believe that cetuximab has very little value in patients with HPV-positive disease. And the real value of that agent really is in patients with HPV-negative disease. This data here also suggests that this antibody, when combined with pembro, tends to perform much better in an HPV-negative patient population. But again, this is a small cohort of patients, 33 patients total. So this data would need to be confirmed in a larger phase 3 study before we can recommend it routinely for patients. Another area of interest is combination of VEGF with immunotherapy. This is a study from Nabil Saba and his group from Emory, looking at the combination of cabozantinib, which is a drug we often use in thyroid cancer, in kidney cancer, and other solid tumors. This is a combination of cabo with pembro, again, showing a very interesting signal of a response rate of 54%. Small group of patients, 36 patients. Again, interesting data, needs to be confirmed in a larger study. But here, what I showed you in these past 3 slides is that we have a good pipeline of drugs to explore in the era of either combining them with pembro or beyond pembro, to start looking at how do we treat those patients who have already seen a checkpoint inhibitor, or how can we improve the results of the checkpoint inhibitor by adding another drug to it. There was, though, one disappointment that we have seen last week. As you all know, we have been waiting for the results of this study for a while. This is a large phase 3 study looking at the combination of lenvatinib, which is a VEGF inhibitor that's used in thyroid cancer and also kidney cancer. So this is a phase 3 study comparing lenvatinib plus pembro to pembro monotherapy. And the study has not been presented yet, but last week we had a press release from Merck and from Eisai, essentially pointing out the fact that this study is a negative study. There's no improvement in overall survival, even though the press release said there was an improvement in overall response rate and progression-free survival with the combination, but no improvement of overall survival. So the study now is deemed as a negative study and would not be pursued further. So that is a disappointment in the field, that combining lenvatinib with pembro does not seem to improve overall survival. Again, we have not seen the data of this trial yet. This was only a press release that just came out last week. Now, I was not gonna really talk. I was not gonna plan to talk about the curative setting in head and neck cancer, but I wanna just in 3 slides summarize where we are today. The bottom line is we do not have currently any indications for using immunotherapy in the curative setting of head and neck cancer. This is the first study we were involved in, which is known as the Javelin 100 study. This is a study that took patients who were gonna be treated with chemoradiotherapy, high risk, primarily HPV negative, combining avelumab to chemo-RT versus chemo-RT. This was a negative study with no improvement in PFS and no improvement in OS. So on this study, the addition of a PD-L1 to chemo-RT did not improve survival. And then last year, a big disappointment came when we saw the results of Keynote 412 study, which was pembro plus chemo-RT versus chemo-RT. Again, no benefit here seen in the primary endpoint of event-free survival or overall survival. So what I would say is that in 2023, there is no role of combining immunotherapy with chemoradiotherapy. So I'm gonna move on now to talk briefly about some of the biomarker work we have done with these trials. The first publication we had on this came last year when we looked at the influence of tumor mutational burden, gene expression profile, and PD-L1 expression on the response to pembro in head and neck cancer. What you can see here in blue is that really we've seen a good association between some of these biomarkers we looked at and response. So we looked at TMB, and you can see here that high TMB had better response. We looked at the neoantigen load. We looked at PD-L1. And more importantly, what seems to be consistent across the board is the T cell inflamed gene expression profile as a predictor for response to immunotherapy. The reason this work, obviously, this and other work is important is knowing that the response rate to immunotherapy is around 20 to 40%. We constantly are looking for biomarkers of response or biomarkers of resistance to try to really have a better sense of who are the patients who are likely to benefit from these drugs compared to those who are not likely to benefit from these interventions. And here's same association we've seen with PFS and OS. This is work from the Keynote 012 trial with pembrolizumab single agent. And when you look at the correlation of these biomarkers, you start to see even higher response rate. For example, as you see here, if you have a high TMB and a high CPS, your response rate goes up to 40%. And the same thing if you have a GEP that's non-low and a high TMB. And for example, if your CPS is low, less than 1, and TMB high, response rate is 0%. So again, associations are of interest, and there are things that we continue to explore and look at and trying to really have a better sense and understanding of the patients who would respond versus those who would not. Another work we are involved in extensively is the AstraZeneca program with durvalumab and tremelimumab. Tremelimumab is a CTL4 inhibitor and Durva is a PD-L1. And also on this study, we looked at two factors. One is the tissue TMB, and the other one, which was more novel, is the blood TMB, which would be a much easier test to do because it's just a blood draw. Again, we saw similar results here. Like when you look at the tissue TMB, 9.9 months in the high expressors versus 4.4 months in the low TMB group. So again, TMB in this study seems to predict those patients who are likely to respond to this drug. More interestingly, when we look at the blood TMB from this large phase 3 study known as the EAGLE study, again, we saw hints that at certain cutoffs, those high TMB patients with now this is a blood TMB predicted a higher response rate and a higher overall survival, 8.1 months versus 7 months versus 4 months with the standard of care. So again, biomarkers of interest in helping us understand who is responding to these drugs and who is not. And these are the conclusions of this biomarker work that we have done on a number of these phase 2 and phase 3 studies the past 5 years. Now, my last section, really, I want to talk about what's coming the next 5 to 10 years. What are we likely to see in our clinics? What drugs, what targets? You know, when we think of the cancer immunity cycle, we really see, we have come to know a lot of steps now and a lot of targets. What's shown here in this cartoon, really a very interesting and seminal work and review on the cancer immunity cycle. Everything in green here is stimulatory factors, and everything in red are inhibitors. For example, PD-1 and PD-L1 would be in the inhibitors. And also in that red, in the red cycle, you see the LAG-3, for example, another very important target. So everything you see on this cartoon here, you can think of these as potential targets that are likely to start to being explored in the clinic in the next 5 to 10 years. And some of these are already in clinical trials. I'm going to show you some of them. The one that has really gathered a lot of interest and attention is the LAG-3. So as you all know, LAG-3 is currently used in melanoma patient as one of the interventions we have. LAG-3 expression does occur on T cells and also other lymphocytes. The ligand there is MHC class 2. And we know that LAG-3 signaling limits antigen-specific T cell response. And we also have come to know that LAG-3 and PD-L1 co-expression does really cause T cell dysfunction and can be an important target in cancer therapy. Also, we know a lot about TIM-3, another target in the checkpoint cycle. TIM-3 expression does occur on CD4, CD8, Tregs, and also the signaling of TIM-3 is a negative promoter of immunosuppression in the cancer cycle. And TIM-3 targeting has become also an important tool in the clinical trial arena in head and neck cancer. And here I show you an example of a trial that we are leading here that is really looking, it's a randomized phase 2 trial looking at 3 arms. One is the PD-1 alone, that's the first arm, arm A. Arm B is PD-1 plus LAG-3. And arm 3 is PD-1 plus LAG-3 plus TIM-3. So here we're looking at the benefit beyond just PD-1 inhibition in patients with recurrent metastatic head and neck cancer, looking at now LAG-3 and TIM-3 in combination with the PD-1. This is another example also of another. So there are many LAG-3s in the clinic right now. Here I only show you 2 of them. The first one was the Insight one, and this is another drug that's also in the clinic being explored in combination with pembrolizumab. So LAG-3, important target. We have drugs in the clinic. They are in clinical trial. They're not part of the standard of care yet. Another pathway that is also relevant and important is known as the SERP alpha CD47. This is also a mechanism for NK cell function. And inhibition of this SERP alpha CD4 axis does enhance NK cell tumor killing. And we do have now a number of drugs that target this pathway. Many of them. I think the last time I looked at this, there were more than 10 agents that are looking at this pathway, at this axis. This is one example of a CD47 blocker from a company called ALX. This is ALX 148, looking at the CD47 blocker with pembrolizumab, comparing that to pembrolizumab single agent. So again, another target that is in clinical trial, not a standard of care, but something you will continue to see in the next 5 to 10 years. This is a combination with pembro chemo plus the CD47 blocker. Another important pathway that I'm sure you have heard about is STING, which is another way of activating APCs by type 1 interferon, trafficking of the effector cells into the tumor cells. The problem with the STING pathway has been really the toxicity, and many of the trials we have been intratumoral injection, which can be quite challenging. It's not very straightforward to give intratumoral injections. There might be a venue to look at these agents as intravenous or PO, but again, the toxicity could be quite significant. And I am still waiting to see really strong data with STING. We don't have strong data right now in head and neck cancer, but it's definitely a pathway that's being explored. This is an example of a trial of a STING agonist in combination with pembro. This is an intratumoral injection of a STING agonist. The one that I am very excited about that I wanted to also share with you is this CD226 axis ligands shown here. This is what's known as the PVRIG CD96, really a new pathway for checkpoint inhibition that's shown here on this cartoon. I encourage you to go and look at this paper and read this paper in Cancer Discovery. There will be a number of trials targeting this pathway in the clinic later this year. So these are not really abstract concepts. These are not abstract molecules. These are drugs that are currently being launched into clinical trials that will be available to our patients in 2023. So stay tuned for these 2 targets, TIGIT, PVRIG. Here what I show you, phase 3, phase 2, phase 1, preclinical. But the reason to show you this is for you to see the number of drugs that are being explored as part of this DNAM-1 axis. So there's really a large number of agents that are coming to the clinic in clinical trials, again, to try to look at options for patients, either in combination with the PD-1, PD-L1, or after PD-1, PD-L1. This is an example of a TIGIT trial that's running now as a randomized phase 3, randomized phase 2 trial. So my final slides, checkpoint blockade. This is the current standard of care in patients with recurrent and metastatic head and neck cancer. I strongly believe every patient with recurrent metastatic disease should have access to a checkpoint inhibitor in the course of their treatment. It's really important. These are important tools to treat our patients with head and neck cancer. Post-checkpoint inhibition, the standard currently is chemotherapy with or without cetuximab. As I showed you, there is a very large number of new targets of interest, LAG3, TIGIT, TIM3, 226, PVRIG, STING, CD96. All of these are in clinic or will be in clinic this year. So really, we have a lot of interest in these new agents, a lot of excitement, hopefully new treatments for our patients. As I showed you, there is synergy with VEGF, PD-L1 with the Cabo data. There is synergy with PD-L1, EGFR, but we do need larger confirmatory trials. Thank you very much. It's a pleasure to speak to you today. I look forward to our panel discussion later.
Thank you so much, Prof. Haddad. Thank you. Sure, I think that's really a synopsis of what we currently have, and I think a lot of new data that you actually showed us that I really would like to hear from the panelists. And maybe I could just quickly say, if there's any questions, please feel free to post the questions in the Q&A box that can be discussed. If there's an urgent burning question, we can always discuss that at the now or after Professor Zafariu. Otherwise, we can leave that for the end. I quickly just want to introduce another panelist that I didn't forget. I specifically left her for now, and that's Dr. Lisanne Langenhoven. Dr. Langenhoven, good evening, and welcome, and thank you so much for being part of the panel. Dr. Langenhoven is a clinical and radiation oncologist, completed studies in 2014. She then joined the Panorama Mediclinic in Cape Town, and she's also a founding member of the Panorama Center for Surgical Oncology, multidisciplinary unit of excellence in the treatment of breast cancer, head and neck cancer, and gynecological malignancy. She also has a specific special interest in the management of cancer-related pain. So good evening, Dr. Langenhoven. Thank you very much for being part of the panel tonight. We really appreciate that. Thank you so much. Welcome. And then our next speaker, Professor Zafariu. Good evening, Prof. Thank you so much once again for your willingness to be part of this. I'm quite excited also to listen myself at your talk. I think what you guys did at MD Anderson, specifically on anaplastic thyroid carcinoma, is astonishing. I mean, you recently gave a talk similar, I think, at the World Thyroid Congress, and I mean, that was, according to me, the topic of discussion at the Thyroid Congress. So, Prof. Zafariu, thank you so much, and we are all excited to hear your talk. Thank you so much.
Okay, hopefully everybody can hear me and see the screen well here. So just to say, it's a real honor to be here today with the South African Head and Neck Surgery Oncology Society. Really, and just to be with such a renowned group of panelists, and just to hear Dr. Haddad's talk before. So my talk will not be nearly as eloquent. I'm a surgeon and not an oncologist, so my talk will not be nearly as eloquent as Dr. Haddad's, but those of you who are surgeons in the audience will understand, and we'll still have a great discussion here. So I've been asked to speak today about immunotherapy and the management of anaplastic thyroid cancer. This is our anaplastic thyroid cancer team at MD Anderson Cancer Center in Houston, where I work, and just want to give credit to the entire team for sort of this body of work. So before we to get into the meat of the talk, which probably will be about 25-30 minutes today, I do have research funding for clinical trials from Merck and Eli Lilly to disclose, and that funding comes to my institution, of course, not to me personally. Just to give a little bit of background about anaplastic thyroid cancer, I think this is important. We'll take the first maybe 7-8 minutes to just discuss some of this background, and then we'll get into the immunotherapy aspect. But I think this is a very important context, because the landscape has completely changed for anaplastic thyroid cancer in the last 5 to 10 years. Used to, it was a disease that was, as we all know, was uniformly fatal. People would be sort of quoted, a month or two survival and not much that could be done. Although certainly we've always tried traditional chemotherapeutic approaches, radiation and surgery in a few patients, but it's really changed over the last. Our understanding has changed, and that's largely due to the molecular understanding of the molecular makeup of the tumor. And fortunately, we now have some drugs, targeted drugs, and also immunotherapy to target it. So, but to speak about the sort of the etiology of anaplastic thyroid cancer really gives you some insight into the molecular alterations that may be driving the cancer. And so, when we think about thyroid cancer, of course, we've got, in terms of differentiated thyroid cancers, we have the papillary and follicular and Hürthle cell. And these differentiated thyroid cancers have particular mutational profiles. We know that the papillary cancers have a high prevalence of BRAF V600E mutations, about 60%. We know that the follicular cancers more commonly have RAS mutations. About 50% of those have RAS. And then Hürthle cells also have a smaller percentage of RAS mutations. And we don't see the BRAF mutations in the follicular or Hürthle cells. So we see a really divergence in terms of this BRAF-RAS story, in particular between the papillary cancers and the follicular cancers. And so as we get to the poorly differentiated thyroid cancers, we start to see more late event mutations, the P53 mutations, TERT promoters, PI3K mutations. TERT promoter mutations may be about 20% of poorly differentiated thyroid cancer, whereas you get to anaplastic, you get about 35%. Same thing with P53. You have a higher incidence in poorly differentiated, but the highest incidence is in the anaplastic patients, about 60% of anaplastic patients having P53. Unfortunately, we don't have good targets as of yet for TERT or P53. But we're going to talk a little bit about some of the targets we do have. So I think the first important point is we really need immediate fast somatic genomic interrogation in anaplastic thyroid cancer, because this is such a fast growing tumor. And we've all seen that this tumor grows day by day, not even week by week in many cases. And so we really need to be able to get when possible, obviously according to the setting, get the genomic molecular mutation done very quickly so that we can get patients started on the appropriate therapy. And that molecular testing can be done by next generation sequencing panels, which are available at most academic centers. Also, commercial tests are available depending on which country you live in. In the United States, there are several commercial tests. These panels, whether they be at your individual institution or commercial panels, typically have a couple of week turnaround. So we don't typically rely on these for sort of the fastest results in terms of molecular testing of tumors, although they are perhaps the most reliable. So for anaplastic thyroid cancer, we really want to be sure that we have BRAF by immunohistochemistry available, and that's done off of a cell block or a core biopsy, and your pathologist can do this IHC test. It typically takes about 48 hours for that test to come back, and that's really the first test that you need to really differentiate these anaplastic tumors, is whether they're BRAF mutated or not, because we do have very good therapy for BRAF mutated anaplastic thyroid cancer in 2023 that is both effective, and it's very rapidly effective as well. So there's also circulating DNA panels, so-called liquid biopsies, that can be done. They're very reliable for anaplastic thyroid cancer. We published on this because these tumors shed so much tumor into the blood. They're less reliable for less aggressive tumors, which may not shed tumors into the blood. So when we think about anaplastic thyroid carcinoma, and I really think that this will one day be a more formalized stratification, but this is just sort of a less formal stratification, but it's an important understanding that we need to have. is that you can really break these down into BRAF mutated anaplastic thyroid cancers and those that are RAS mutated. So that's the second group. So this is a study of 202 patients at MD Anderson. The top two lines, really the top two rows, is really where we're focusing here, and that's where you see the top line is the BRAF mutated, in the second row is the RAS mutated, and you see that these are mutually exclusive. So you don't see overlapping. You may see an overlap in one or two patients, and that's typically due to patients that have been on therapy and developed resistance mutations. But de novo, you really don't see a BRAF and a RAS coexist together. And that really goes back to that original slide I showed, which goes back to the etiology of these tumors. These BRAF mutated tumors are typically going to be papillary derived tumors that originated as a papillary cancer and dedifferentiated to an anaplastic BRAF mutated anaplastic cancer, whereas the RAS mutated are going to be follicular or Hürthle cell cancers that dedifferentiated to a RAS mutated anaplastic cancer. And then we've got another third of the anaplastic cancers which have neither a BRAF nor a RAS mutation. So you can really think of these as BRAF mutated, RAS mutated, and neither BRAF nor RAS mutated. And so there's prognostically, these patients, there's a difference, and this difference is largely due to the therapeutic effect, which we'll talk about. But the BRAF mutated patients are going to do the best, and this is a very significant difference here. Whereas those with BRAF and RAS those that are neither BRAF nor RAS mutated are kind of in the middle, and those that are RAS mutated typically do the worst. And that's and so we're going to talk first about the BRAF mutated tumors, and then we're going to talk about those that are not BRAF mutated. So about 40%, as mentioned, of anaplastic thyroid cancers are BRAF mutated, and so that's where we'll sort of start our discussion, because we have such good treatments. There is FDA approved treatments for, in fact, the only anaplastic thyroid cancer specific FDA approved treatment is dabrafenib and trametinib, which is a BRAF MEK inhibitor approved for BRAF mutated anaplastic thyroid cancer. The other FDA approved, and this is speaking of the United States in particular, drugs that can be used for anaplastic thyroid cancer relate to the fusions, and these are rare patients with anaplastic thyroid cancer can still have an NTRK or a RET fusion, and these are sort of agnostic. These drugs are sort of agnostically approved by the FDA for any thyroid cancer with a fusion, which could include anaplastic thyroid cancer. So these are some of the drugs that are FDA approved for patients with anaplastic thyroid cancer, specifically in the case of the BRAF mutated ATC for dabrafenib and trametinib, and then sort of this agnostic indication for those that have fusions. So in BRAF mutated anaplastic thyroid cancer, the neoadjuvant use of the BRAF MEK inhibitor, and with or without immunotherapy, will make many unresectable tumors become resectable. So that's an important point. And you see the plus or minus immunotherapy, and we'll get to that question shortly. But we published this about 4 or 5 years ago now in thyroid. So really the dramatic differences that we see pre versus post treatment in patients with BRAF MEK inhibitor and immunotherapy, before and after treatment, going from unresectable tumors to resectable tumors. And so as a surgeon, this was very interesting to me and exciting to me, because this has been, historically a disease, is all the surgeons on this webinar will attest to, that, there's always a few anaplastic patients that are operable, but the vast majority have never been operable. So they've been patients like this patient on the left that's unresectable. There's carotid artery encasement. And so after 3 months of dabrafenib, trametinib, and pembrolizumab, we converted this particular patient to a very resectable tumor. This is the same sort of level. You see the clavicles here at the same level, and you see now the carotid is free, and you've seen a really dramatic response here. And so that dramatically changes what other treatment options may be available for these patients. So and you also see this in terms of not even just unresectable tumors. So this is a case where, there's tumor in the trachea, involving the larynx, at the top picture, to a post-therapy scan, which is about 3 months after triplet therapy with BRAF/MEK inhibitor and immunotherapy. And we see, this is no longer, we no longer see the tracheal and laryngeal invasion. We're able to do a much less morbid surgery. So, so you may ask, well, why do we even need other treatments? If this BRAF-directed therapy, we have this, it sounds, wonderful. And it is. It's really been a game changer. But why do we even need anything else if it's working so well? Well, the problem is that it works well for a time in most patients, but I wouldn't say invariably, but almost invariably, patients will ultimately begin to progress on the BRAF/MEK inhibitor alone. And so that's why, and this is sometimes as quickly as after a couple of months of the BRAF/MEK inhibitor. Sometimes it takes a year or two, but almost invariably patients will develop resistance. And this sort of was published in JCO a year or two ago now, but sort of looking at patients who, these are all patients who have BRAF mutated ATC, and this is not a study that we would do in 2023 at this point, but in terms of prospectively, but it is a study that we can do retrospectively because we know how well the BRAF-directed therapy works, so we wouldn't not treat a BRAF mutated ATC with this approach. But when we compare our historical sort of cohort of BRAF mutated patients who were not treated with BRAF-directed therapy to those that were treated with BRAF-directed therapy, obviously we see a huge difference, and that's just the use of the drugs. But we also see the other sort of point of this slide is for this top curve, which is the BRAF-directed therapy, you also see a significant fall off in this first year or two in survival. And that's because although these patients do a lot better than they would do if they weren't on the BRAF/MEK inhibitor, they are still developing resistance, and some of these patients are dying. And so that's why we have to do more than just the BRAF/MEK inhibitor for this 40% of patients who have the BRAF mutated anaplastic thyroid cancer. And this is an example of a patient that our group published, led by Dr. Cabanillas, who's an endocrine oncologist who really has led a lot of the work that in this field, is looking at sort of the baseline thyroid and the baseline mutation. So this patient on the left had a BRAF mutation, an ATM mutation, and an MCL1 mutation. And so this patient had a really great response to the BRAF/MEK inhibitor, but about a year later starts to develop a scalp metastasis here, a posterior neck sort of scalp metastasis. And we look at the mutational profile of this tumor, and there's an emergent KRAS mutation, which sort of, that's the sort of the pattern of resistance. It's the one time that you will see a BRAF and a RAS mutation together, at least in an anaplastic thyroid cancer, is typically it's an emergent mutation that has developed after therapy. And so, so this is the example of why we need more than just BRAF/MEK inhibition. And so, while we've seen a dramatic improvement in survival for these BRAF mutated anaplastic thyroid cancers, the rapid drug resistance is a major issue, and we need multidisciplinary treatment strategies. So, we will. I think I'll mention surgery for a couple of slides in this talk for the surgeons, but also, radiation therapy. How do we integrate that into the treatment of these tumors, along with the targeted therapy, and then immunotherapy? And we'll talk shortly about the immunotherapy. I think I have a couple of slides until we get into that discussion. But I wanted to, since we do have a lot of surgeons in the audience, I did want to show, we just published this study about 6 months ago in thyroid. So this was 32 patients who have had neoadjuvant BRAF/MEK inhibitor and immunotherapy. And we looked at the upfront sort of resectability of these tumors using a score, a surgical morbidity score. And we looked at the post treatment sort of look at the imaging. to look at the morbidity score. And sort of, this is, I illustrated this in a few slides earlier, but if you look to the right of the screen, you see this as an example. Pre-treatment, you see the carotid is encased here. That would be an unresectable tumor, of course. Post-treatment, the carotid is no longer encased. So that would be, depending on other structures that may still be at play, moderate or mild involvement here. So we saw a significant reduction in the morbidity of what the surgery would be after treatment with the drug. And the other interesting thing, that we've looked at is our pathology after, when we do these surgeries on these patients. And this really speaks to both the prognosis and also the etiology of the disease. So these are all BRAF mutated anaplastic thyroid cancer patients. So again, within this particular study, we looked at 32, and after the BRAF MEK inhibitor with immunotherapy, and we do the surgery, and we see 60% of these patients only have residual PTC in the specimen. That is, they've had this rapid and dramatic response, and you do the surgery and you remove the residual thyroid with some lymph nodes, and there's only PTC in 60% of the specimens. There's absolutely no ATC in there anymore. And so those patients, their prognosis, they do much better than those who have residual ATC in the specimen, whether it be mixed residual ATC and PTC or just ATC. Has a poorer prognosis if there is residual ATC in the specimen. So in this, really, almost all of these patients, when you add up the numbers that have either PTC only or PTC and ATC, over 80% of those have some degree of residual papillary cancer in the specimen, really suggesting that these tumors, they're not de novo tumors. They're really tumors that are that really de-differentiated from papillary cancers. So I think that really does give us some insight into how these tumors develop. So in this particular study that I mentioned, we did publish our surgery after BRAF MEK inhibitor and immunotherapy group. I think the main point I wanted to show is this top line, these 32 patients who had surgery after BRAF-directed therapy. When you look at 2-year survival, for example, we have an 80%, over 80% 2-year survival, which for an anaplastic thyroid cohort is quite remarkable. And so, why immunotherapy for anaplastic thyroid cancer? And so, I'm going to talk now about that. And I'm going to integrate some of the data that we've already talked about, but I think it was important to have this background. So anaplastic thyroid cancer is highly immunogenic. PD-L1 expression is up to between 2/3 and 90% of patients are going to have PD-L1 expression, and it's often high. There's also synergy. We talked a lot about the BRAF MEK inhibition. We'll talk about those that are BRAF wild type shortly as well, but there's also synergy between the BRAF MEK inhibition and immunotherapy, such that we see increased T cell infiltration in BRAF mutated ATCs, and also upregulation of PD-1 expression in tumor cells. So I mentioned this paper earlier, this JCO paper, where we looked at over 200 anaplastic thyroid cancer patients at MD Anderson and looked at their survival outcomes. So we don't have any prospective randomized trials on immunotherapy in anaplastic thyroid cancer. So hopefully one day that will change. This is something that we're trying to work through in the NRG group right now. But in the absence of that, we look at some retrospective data we have. We also look at some clinical trials, prospective clinical trials that have been done. So we'll look at those here. So first, retrospective data. So benefit of immunotherapy to BRAF-directed therapy. So this suffers from all of the sort of limitations of retrospective study. But when you look at the overall survival and the progression-free survival of anaplastic thyroid cancer patients who have gotten immunotherapy versus those who did not, again, with the limitations of retrospective, review here, we do see a significant difference in those who have received immunotherapy. So that's the first point I wanted to mention. Secondly, when we look at, I'm going to try to move. I apologize. When we looked at the ROAR study, which was the original dabrafenib trametinib study that was led by Vivek Sabaya at MD Anderson, this is what led to the FDA approval of BRAF MEK inhibitor for anaplastic thyroid cancer. We see a median overall survival in that study of about 15 months. And so when we look at another clinical trial, which is a triplet therapy, which is the vemurafenib, cobimetinib, and atezolizumab, which is a BRAF MEK inhibitor combination plus immunotherapy. So instead of the just BRAF MEK inhibitor, now you're adding the immunotherapy. In this trial, you see a 2-year overall survival of 67% alive. So although these are two different clinical trials, and there's caveats with comparing one clinical trial to another, we do see, the difference between a 2-year overall survival of 32% back at the ROAR study and 67%. It's essentially over double the 2-year survival when we look at this clinical trial. And this is a clinical trial that's been presented at ASCO. It's been presented at ATA. And it will soon be published in the literature, and I'll get back to this trial later when we talk about BRAF wild type. So this is sort of the comparison when you look at the triplet therapy that includes the atezolizumab, which is the immunotherapy PD-L1 inhibitor, comparing to just the BRAF MEK inhibitor alone, and looking at that 2-year overall survival, as I mentioned. For those of you, probably not many of you, but for those of you who will be going to the American Thyroid Association meeting, which is in Washington, D.C. in 2 weeks from now, we do have another study that we are excited to present the results for dabrafenib trametinib versus dabrafenib trametinib and pembrolizumab for BRAF V600E mutated anaplastic thyroid cancer. And we do show a very significant difference in overall survival when you compare the triplet to just the doublet without the immunotherapy. I'm not going to go into the details of that results because I don't want to spoil the oral presentation, but we will have this data not only available soon, but also hopefully published soon. So in terms of other perspective, we talked about the vemurafenib, cobimetinib, atezolizumab, which is a BRAF MEK inhibitor immunotherapy clinical trial. Our current clinical trial is looking at another triplet combination, which is the dabrafenib trametinib, which is the FDA approved agent for BRAF mutated anaplastic thyroid cancer, and then plus pembrolizumab. So, and this is a trial which is 40 patients. It's a multi-center trial, and it includes a dabrafenib trametinib run-in for 3 weeks, which is then followed by 3 to 5 cycles of the triplet therapy, which is dabrafenib, trametinib, and pembrolizumab, which is then followed by surgery. In the vast majority of patients who were able to undergo surgery, there's always going to be a small percentage who remain surgically unresectable for some reason, for either because of their distant disease, it's not a win-win situation, or because of the response is not as robust. But the vast majority of patients in this trial, so far, we've enrolled 28 of 40 patients have undergone surgery, and then after surgery they have the option of radiation therapy, and then they go back on the drug, the DTP, after surgery. And so we do have 6 sites within the U.S. As mentioned, we've enrolled 28 of 40 patients so far, and we think this trial will probably be open for enrollment for another 6 months. And then we should be able to complete the 40-patient enrollment. So we'll have the results of this hopefully in a little over a year. So for the BRAF mutated anaplastic thyroid cancer, we've seen rapid and dramatic results, decreased surgical morbidity, and some long-term survival. I wanted to mention briefly, before we get to the BRAF wild-type tumors, and I'm going to talk about immunotherapy for the BRAF wild-type tumors, but I did want to briefly mention that in addition to the BRAF mutation, the other sort of potentially targetable mutations that are actually not a mutation, but a fusion that I mentioned were the RET fusions and the NTRK fusions. And so this is only about 1% of anaplastic thyroid cancer, but there are drugs, there are NTRK inhibitors and RET inhibitors that are available. I don't have time to really get into the data for those studies, but if you have a tumor that's BRAF mutated, that's usually going to be mutually exclusive with the RAS mutated. But if it's neither BRAF nor RAS mutated, that's when really you can check for the fusions, because the fusions also tend to be mutually exclusive with the BRAF mutations. And that's similar to what you see in papillary thyroid cancer, right? So in papillary thyroid cancer, you don't see BRAF mutations coexist with fusions, and so this again goes back to these tumors really are derived from the more differentiated tumors. And so for BRAF wild type tumors, I'm going to talk about sort of systemic therapy, and I'm going to very quickly here get to the systemic therapy with immunotherapy, because as is evidenced by this study, which was a study of lenvatinib for ATC in Japan, and this is also consistent with other studies in our experience, is that the patients who have response, which per RECIST response, is going to be the minority when you're using a single agent targeted therapy. Even lenvatinib, which is one of the more potent anti VEGF drugs used for thyroid cancer. So the targeted therapy alone, whether lenvatinib or another drug, is typically very low. And again, the median overall survival in this study was only 3 months. So similarly, when you look at immunotherapy alone in anaplastic thyroid cancer, this was a study from Boston. Lori Worth led this study. This was 42 AT patients looking at single agent immunotherapy, and the response rate was only 19%. So you don't see many patients who have response. You see, in this study there were 3 patients who had a complete response out of 42, and then a handful of patients who had partial response, and all the rest did not have response, according to RECIST. So I think immunotherapy alone typically doesn't work well either. So then you look at the combination of immunotherapy and targeted therapy, and I'm glad Dr. Haddad went first, because he mentioned the pembrolizumab lenvatinib story that has recently been sort of in the press with regard to recurrent metastatic squamous cell carcinoma in the head and neck. But it's may not be exactly the same when we're talking about anaplastic thyroid cancer. So this is a look at some of our data that was published in 2018, looking at lenvatinib and pembrolizumab this is looking at any combination of immunotherapy with targeted therapy for anaplastic thyroid cancer. But the patients who tended to have the best responses over here on the right were those that had the lenvatinib pembrolizumab. So and when we look at sort of our best response, so this is looking at I think this is 17 patients who had lenvatinib pembrolizumab in BRAF wild type anaplastic thyroid carcinoma. We see about 64% have a partial response and 7% have a complete response. So that's what we've seen at our institution. So that's a pretty significant rate of response. That's a 70% response, either partial or complete response. in these 14 patients who had lenvatinib plus pembrolizumab for BRAF wild type, non-BRAF mutated anaplastic thyroid cancer. So, and this is an example, this is a patient that we treated, an example of a really good response, because pictures are worth 1,000 words. So this is a patient with an NRAS mutated anaplastic thyroid cancer who had lenvatinib and pembrolizumab, and you can see obviously the distant disease here in the lungs and the mediastinum, and had a complete response after therapy. So I'm not saying that that's the norm. When we look back at the small series of patients, it's rare that you have a complete response. It's more common to have a partial response, but we do see that occasionally. So Christine Dirks and the group from Germany presented this clinical trial, phase 2 trial of ATC in poorly differentiated carcinoma with lenvatinib and pembrolizumab at ESMO in 2022, and they looked at patients with lenvatinib and pembro, and they didn't see any patients of these 27 patients. None of them had a complete response, but 52% of them had a partial response, whereas another 48% had stable disease. So that not bad when you're talking about a BRAF wild type anaplastic thyroid cancer population of patients. And this is just comparing this to single agent lenvatinib. We could have a similar comparison to single agent, immunotherapy. Really, it's the combination here where we feel in BRAF wild type anaplastic thyroid cancer that has the potential to give you somewhere in the 50% to 70% response range. So when you look at the survival, in this ATLEP study that was published by the German group, the median overall survival in this group was 11 months, 44% 1-year survival. So not anywhere near what we're seeing with BRAF mutated anaplastic thyroid cancer these days, but better than historically what we've seen with a 2 to 3 month survival in anaplastic thyroid cancer patients. So our current sort of clinical trial that this is a trial that's led by Maria Cabanillas for BRAF wild type patients who have unresectable or metastatic BRAF wild type anaplastic thyroid cancer, is to use pembrolizumab and lenvatinib. We've enrolled now about 12 patients on this study. I don't have any data to share with you today with regard to this study because it's still very early, but we're seeing patients who are having partial responses, and some of these patients are then able to go on to have surgery, and so we look forward to sharing the results of this trial also in the coming year or so. So finally, to mention a trial that I mentioned this trial earlier, which is this trial has been presented at ASCO, it's been presented at ATA, and hopefully will be in the published literature very soon. I think Maria, who's the lead of the Cabanillas, the lead of the study, is finalizing the paper now. But this trial not only looked at the BRAF mutated tumors, so it also looked at a group of tumors that were RAS mutated. So I've already sort of mentioned this sort of cohort 1 that was the BRAF mutated that had the BRAF MEK inhibitor and immunotherapy, but there was also a cohort 2 that were RAS or NF1 mutated that had a MEK inhibitor, cobimetinib, plus immunotherapy. So when we're talking about immunotherapy for BRAF wild type tumors, I also wanted to at least just show the results of this cohort 2. We talked about, again, lenvatinib pembro is sort of what our sort of current clinical trial is in kind of what we would currently steer patients toward. But for patients who had the RAS or the NF1 mutation, not a terrible result. There were 16 patients who were enrolled in this cohort that were RAS or NF1 mutated. Their median overall survival was 18 months. So that's a 1.5 year overall survival for a non-BRAF mutated anaplastic thyroid cancer. And their 1-year survival rate was 58%. Hopefully by the time of publication, we'll be able to calculate a 2-year survival rate as well. But you see the curve here, while not as good as what we would see with the BRAF mutated cohort, there is some hope that with combination targeted therapy and immunotherapy here, that we are making a difference in these non-BRAF mutated anaplastic thyroid cancer patients. So we published this study in JAM Oncology a couple of years ago, really demonstrating this data is a couple of years old now, but demonstrating how we've significantly and progressively improved the median overall survival of our anaplastic thyroid cancer patient cohort. This is a study of about 500 patients from MD Anderson, and really, this is a lot of this is due to targeted therapy, but we think some of this is also due to the immunotherapy effect that we've demonstrated in this talk. So, last slide in summary, our retrospective and recent clinical trial experience support tri-modality neoadjuvant therapy, the BRAF MEK inhibitor plus immunotherapy for BRAF mutated anaplastic thyroid cancer. We also follow that with surgery. Again, we do not have randomized clinical trial data to support this, but maybe in the future we will. But we do have clinical trial data to support it, just not randomized data. And then we similarly, when we look at BRAF wild type, we have prospective clinical trial and retrospective data to support combination therapy, targeted therapy, and immunotherapy. We talked about specifically the lenvatinib pembrolizumab or the cobimetinib atezolizumab for those that have a RAS or in NF1 mutated tumors. So with that, thank you for the honor of being here today, and look forward to the panel discussion.
Thank you very much, Professor Rafario. I think that was really quite a nice synopsis of where we are at the moment for anaplastic thyroid carcinoma, and I think this is really, I must congratulate you guys what you did. Because the perception, from students, registrars, consultant levels, anaplastic thyroid carcinoma is a death sentence. And I think, as you mentioned, 80% of your patients, BRAF positive patients, they get 2 years of survival, and I think that's amazing. I want to actually ask all the panelists if you'll be so kind to put on your videos now, and as a quick introduction, can I quickly ask and go around the South African panelists and just ask their opinion and the South African experience quickly, maybe just each and every one a short perspective of what we see in South Africa, what is our limitations, what is our obstacles. We can definitely talk about funding. And then Dr. Torres, I think that I'm going to hand over to you if you don't mind. Thank you. Dr. Vetter?
You want me to go first? Okay.
Yes, please.
Right. So as you mentioned when you introduced me, I work in a state hospital. I think I'm possibly the only person here. Well, actually, Karen also works in a state hospital. So our experience with patients, in state practice is very much, focused on radiotherapy and chemotherapy. We don't generally have access to any, what, if you want to call it as an umbrella term, any biological agents, except for lymphoma and also some patients with breast cancer. So, and that's Herceptin, obviously. And so even those patients, the consultants in charge of treating those patients would have to select a certain number per year that would be eligible for that type of treatment because of its expense. Even though the drug companies do try to make the treatment a little bit more affordable to state patients, it's still way beyond the budget of the provincial healthcare system. The healthcare system in South Africa, and we service the majority of patients in this country. We have a budget that we have to stick to, and it is generally focused on primary healthcare, a lot of maternal child health and that sort of thing. And so there is obviously money for tertiary care, but it has to be put into perspective and used judiciously. And so we focus, most cancer treatment is really just, chemoradiotherapy. We have got very nice modern radiotherapy machines. We have access to most chemotherapy drugs, not always, not everything. But these agents are not part of our daily management of patients. They're extremely expensive. I'll leave it to the people in the private sector to talk a little bit about what the medical aids are prepared to pay for now. But I do not see in the foreseeable future that our patients will be able to access these drugs. So we do what we can with what we have. And I think we get, we have quite good success, but we don't have this added benefit for patients, especially in the metastatic recurrent setting, to extend their life by a couple of months.
Maybe let's throw it quickly over to the private practice. I mean, Dr. Green, Dr. Vos, Dr. Langenhoven, if I may ask. It's a real problem. I mean, cost is a factor. At the moment we just have Pembro. Maybe opinion from you guys.
Yeah, Dr. Kluger, I think you make it sound as if the private sector has unlimited funds, but the truth in reality is that we're just as regulated. In fact, I think sometimes more regulated. And even if you look at the private sector, if we could just quickly put it into context, if you currently have 10 patients with metastatic head and neck cancer, and you plan on giving each one of them pembrolizumab for 2 years, by the end of the 2 years, you'll be able to install a brand new Linac for the same price. And this is the reality we're facing in the third world, is where we have access to first world medicine, but we're still stuck in third world funding models. And the reality is that you're going to find it hard to justify palliating patients with these expensive drugs when there are thousands of patients that are waiting 3 to 6 months to have possibly curable head and neck cancers treated. And this is, I think, as relevant in the private sector as it is in the public sector. Roughly speaking, a 200 milligram fixed dose of pembrolizumab currently in private practice is about 90,000 Rand. So 90,000 Rand, I think, is about $6,000 or $7,000 every 3 weeks. So it comes to roughly 3.5 million Rand a year, which is hard to justify. Some of the top medical plans will cover that, but they inadvertently leave patients with up to 20% co-payments. Now, for the average patient to pay up to 20,000 Rand a month for a drug that might add 4 months to median overall survival, again, is hard to justify. And very few patients have that kind of money simply lying around. I always tell them, if you have 20,000 Rand lying around, you'll likely end up buying a jet ski or something similar. Very few people have that. So the reality in Africa and in the third world is that cost is always going to be the limiting factor. So even though we have access to the BRAF inhibitors, we have access to most of the PD-1 antibodies, cost is always the limiting factor.
What about, I think you both are raising really, I think, very important and relevant questions that, we are faced with. Part of my work with NCCN, we have spent quite a bit of time coming up with what we call the harmonized guidelines for head and neck, for thyroid, where we really are building guidelines that are targeted towards specific regions of the world and even countries based on the resources available at those countries. For example, if you take the thyroid cancer, for example, and you look at the available options for papillary thyroid carcinoma, you're going to see lenvatinib, you're going to see sorafenib, you're going to see cabo. And the idea there is, okay, there are multiple VEGF inhibitors. We as a panel think maybe this is the one that's most relevant and the most effective. So instead of having access to all of these VEGFs for governments and for organizations to pick one of the ones listed on NCCN, so at least there is one option available to patients. I think, the cost you had mentioned, in terms of, being able to put in a radiation machine, obviously, I think totally relevant. I wonder whether there might be a mechanism to think about this in terms of also being more thoughtful about maybe, you know, when I showed you my presentation, you tend to see that those high CPS expressors, for example, tend to be the ones that have a better response to these agents. I'll tell you, as someone who has I've been doing head and neck cancer for 22 years now. Even though I do look very young, I've been doing this for a very long time. So I can tell you that we have seen really quite impressive and profound responses to immunotherapy in the recurrent metastatic setting. So I always feel like it's really a shame not to be able to offer the patient immunotherapy when they have recurrent metastatic disease. I understand all the issues around cost, and it's really a shame that companies would not provide, you know, for under-resourced areas of the world, those drugs at a much lower cost or subsidized cost so that patients could benefit. And the fact is, as you know, as I said, most people are not going to get 2 years. Most people, you know, within 1 or 2 months whether they're responding or not, and then you'll stop the treatment. The question becomes for those people who are going to have a CR or a profound response, and they are going to live a much longer, they have much prolonged overall survival with much lower side effects compared to chemotherapy. How can we as physicians who really are, because none of us, I think, on this call want to talk about money and cost. We want to focus on the patient, but we are forced into talking about cost and talking about money. How can we think of mechanism to make those drugs available to maybe a group of patients who, you know, have higher likelihood of responding, right, and benefiting? And the same could be for anaplastic, because, you know, you think of anaplastic, and Mark can comment on this, like we've made zero impact on outcome with anaplastic thyroid cancer the past 30, 40 years, and people die very quickly. And now we have some interventions where actually we could impact outcome with neoadjuvant therapies for those patients. You can get a BRAF IHC very quickly, which takes a day or two. Maybe you could impact survival for those patients. But these are obviously expensive interventions. They require a functioning multi-D clinic. You're required to have the surgeon and the med-onc working together. And so they're not easy, they're complex. But I think they really can change how we think about some of these diseases where patients do terrible.
There's two hands raised. Dr. Torres Holmes, I don't know if you wanna manage this session, but I mean, Dr. Julie Vetter and Dr. Langenhoven, you raised your hands.
You want to go first, Dr. Kanyile?
Oh, yeah. Thanks. In fact, I just want to echo the sentiment that have been said as well, that we don't have access to these agents. But I just want to ask Prof. Haddad about this Pembro that you give for 2 years. What happened to beyond 2 years? We know in the lung that it hasn't shown that if you go beyond 2 years, there is any benefit. But in head and neck, for those that have responded and you stop at 2 years, and when they relapse, do you rechallenge, or what happens to them? And then the other thing is about this anaplastic thyroid. I don't know what other colleagues of mine from other centers, I've just looked at my own data and see how many of these patients we've seen. And anaplastic thyroid cancer, we haven't seen one this year, and we are a referral center. I think the last we saw was last year. And by the time they come, they are so far gone that whatever you have, you end up with chemotherapy. And if they are lucky, they can get radiation therapy as well. But we don't see a lot of these patients with anaplastic thyroid carcinoma. But I would like to know what happened beyond 2 years for our patients with head and neck.
Because actually, and this is a very good question. I've had a number of patients now who have gone into 2 years, and where we had stopped. Usually what we do is we stop Pembro at 2 years. And only I've had one patient of all the patients where I stopped the treatment where the cancer came back. All the others have remained in remission. And that patient whose cancer come back after I stopped, I rechallenged challenged him with pembro and he didn't respond. He died very quickly. But all the other patients have actually remained in response and did not require re-challenge. The other thing I would mention also is I've had patients who have achieved a CR very quickly to either pembro or nivo, but because of toxicity, I had to stop. So I have a patient who developed severe diarrhea, renal failure, almost died. He actually was 82. So he's only had 2 months of pembro, went into a CR, and then I couldn't re-challenge him because he had such a severe diarrhea and kidney toxicity, which have recovered, but his cancer never came back. So even with 2 months of pembro, he stayed in CR and still in CR doing well. I think my experience with, because we've been doing now this for a few years, is that you know very quickly who's responding and who's not. And I wonder, and those will be great studies to do. I mean, the studies were done with 2 years, but is it really necessary to give 2 years? Is 1 year enough? And then there's the dose issue that Johan has mentioned before. There's data from India that you can give much lower dose and still get the same. So I think, can we as a society think about mechanisms to either just to get those drugs to patients, either by not necessarily sticking to the 2 years, maybe giving less or maybe giving lower dose, but try to get those drugs to patients? And that's an open question. I don't know the answer, but just having seen the profound response with some of these patients, you know, if there's a way to get these drugs to patients anyway, whether through the drug companies or whether through a lower dose or lower schedule or lower duration, I think that would be useful. Maybe Mark can comment on the thyroid. You know, the thyroid, you know, it is a rare disease, but I'm sure Mark sees a lot of it because it's MD Anderson. It is a rare disease.
Yeah, I think we've just to add to your comments. I mean, we've seen similar results, and I think this is sort of a universal finding that, you know, with patients who are on immunotherapy, often the patients who have that really dramatic side effect and you know, adverse events from the immunotherapy are often the ones who respond profoundly. And so it's actually, you know, even though, you know, we may have a patient who has that type of severe adverse event, we're sort of celebrating on the inside because we know that patient's very likely had a significant response, and we see that in anaplastic thyroid cancer as well, with immunotherapy. But I think it is a good question about how long to continue the immunotherapy. You know, 2 years has been, you know, mentioned extensively. 2 years is the sort of the current standard, but I think it very well may be that for a lot of patients that we can use immunotherapy for a much shorter period of time. I think we're afraid for these very aggressive cancers, particularly like anaplastic thyroid cancer. We're afraid to take the patients off of the therapy because we know that the tumors are so aggressive, and we worry that if there is a recurrence that we wouldn't be able to get control. But I think I think that as we continue to have success, I think we will be looking at sort of, it's crazy to think about sort of a de-escalation protocol for anaplastic thyroid cancer. And when I presented a clinical trial idea to the NRG recently, I used that word de-escalation, and there were several comments from the audience that, you know, you can't really use de-escalation, is not really a term that we can use with anaplastic, but I think we will get there. I do think that with the success we're having with these drugs and future drugs, I think we will ultimately be able to de-escalate some of these treatment regimens and use less systemic therapy or for shorter periods of time.
I have a comment to make from the private side in South Africa. So when we consider head and neck cancer, I think I work in an affluent area, and most of my patients don't actually present with stage 4 disease. Most of them still present with stage 1 to 3 disease. And this is actually where it becomes critically important to do your job properly and function in an MDT. So you need, where you can, to try and avoid progression to stage 4. And I think one of the problems we have is that people don't function in MDTs. I think some oncologists and surgeons function on their own and then do a surgery that potentially shouldn't have happened at that point, or refer late, or sit on something or have involved margins because they don't often do this type of work. All of these things are contributing to the stage progression we then subsequently see. So I think the first thing, if you have a resource-constrained environment, is to make sure that we do what we do in a multidisciplinary team, that the decision-making is solid, and that we take the best chance we have in getting a complete response first up. We know we don't need immunotherapy in our curative setting for head and neck. So that's the first thing. I think the second thing is the awareness of the risk factors of HPV in head and neck cancer. I often speak to colleagues that are not aware of the impact of HPV. And in our country, our HPV program followed quite late. I'm in my 40s now, and we were not offered vaccines routinely. So we still have quite a chunk of our population that are not vaccinated, that will have to sort of age with the risk factors of HPV, and also then the alcohol and smoking in addition to that. So, you know, as we get the younger group coming in, hopefully that's been vaccinated and more aware of the disease, we still have this group that we still have to see age throughout. And the awareness of my 3-year-old, hello, and the awareness of this disease, and not just thinking that a lump, we so often see patients come with lumps of a few centimeters in size because they get reassured. So there is a lot we can do without immunotherapy to sort of try and improve our outcomes despite cost. And the last comment I want to make is we have a cheaper, sweetie, just give me 1 second. The last comment I want to make is that, you know, would we be able to use different drugs in the same class, like Tecentriq, where your cost is a quarter of your Pembro? Would that work? Could we start looking at trials where we can use class effect drugs, or drugs at lower cost? You know, even if you can use a class effect with Tecentriq at a quarter of the price and you still drop it by 10% of a dose, you're still going to be able to treat a lot more patients. So we just need to start thinking outside the box, I think. And my child is sorry, guys.
I think it was good comments made, Dr. Langenhoff, and I can just vouch again. I think MDT is, I think that's not a new principle. I mean, MDT is worldwide the way to treat patients, not even head and neck alone. I think it's all cancers. And I think the whole thing about, even in private, I think that the problem that we sometimes have in private is that sometimes it's small little practices operating on their own, and that, like you said, sometimes management is not being, I almost want to say, policed. And then that's when you start getting, like you said, positive margins, patients not managed necessarily appropriately, and ending up with inoperable or metastatic disease. But I think the important thing is, I mean, we do have a private sector, and there is patients that read the internet. There is patients that read the literature and ask about immunotherapy. I mean, we all spoke about the costs. I mean, if I might ask from the panelists around the table, in South Africa, I mean, your usage of immunotherapy, if, like you said, this patient is actually able to pay for it, your experience with that, if I may ask? And then Dr. Fosh, you can also comment.
I just had a question. I mean, we know immunotherapy, I mean, you sometimes have to dig a bit for not necessarily head and neck cancers, but for other malignancies where immunotherapy trials, where we know you can actually use lower doses of pembrolizumab than opposed, say, the standard 200 milligrams. is there any incentive to do trials where you would use a lower dose of Pembro? Like, I mean, even if you were to use half of the dose of, I mean, that would literally be half the price. I think it would be quite relevant to have that information in a resource constrained setting, or would that be a political issue? Would pharma not allow it? Is there, I mean, there must be a hunch that, we can use lower doses than 200 milligrams.
Andre, part of the challenge is that most of the drugs that are available now, Pembro and Nivo, are coming off patent like shortly. So I think one of the issues that we will be faced with, and we're seeing this already, there's not a lot of appetite at this stage to fund trials with these drugs from a drug company perspective, because there's just not an interest. There's a move into now looking into other classes of drugs, and other agents. So I think and again, we don't have pharma represented here, but my personal understanding and sense is there's not a lot of enthusiasm to fund trials at the standard dose with these agents anymore, just because they're coming off patent. So I mean, that's kind of my sense, having dealt with this for a long time. And then obviously the other question that you're asking is there an appetite anyway from a drug company perspective to look at a trial with half a dose? And I can't answer that, but I would expect probably not.
Dr. Green and then Dr. Foster.
I think just to make one or two comments from the private sector side again, is these drugs are available. And I think we've been using it in other diseases for much longer. And it is really amazing to see these complete responses. I think what one would want to do is what Professor Haddad just said, is look at patient selection. And I think it will probably be driven by the academic side of things. But what we're seeing increasingly in patients with MMR colon cancers, patients with specific types of melanoma, is where we are pre-selecting patients who are definitely going to respond well to immunotherapy. And if we can start looking at biomarkers and predictive markers, if we can start finding ways of accurately predicting patients who will definitely respond well to these drugs, who can potentially respond completely and durably, we are then looking at curing patients with metastatic diseases. That's what we're seeing in melanoma. That's what we're seeing in increasingly in lung cancer. And if we can start showing that in head and neck cancers, then suddenly the cost to benefit ratio changes. And if we can then look at selecting those patients that will respond completely more accurately, we're definitely going to bring the cost of the treatment down when we look at the global population. And then, not to defend pharma, but in South Africa and in the private sector specifically, we do have a fund that is driven by a number of the ethical drug companies that do assist patients in paying for the shortfalls when it comes to immunotherapy. So we call it the AICF, or Access to Innovative Care Fund, and they do assist patients who cannot afford co-payments to improve access to these drugs. And it's not that I'm fighting for the pharma companies. It's just that if a patient does qualify for immunotherapy and he does meet the basic requirements, there are ways to get access. It's not that there's no access to these drugs in South Africa, and that's for the BRAF inhibitors, the PD-1 inhibitors, and all the other targeted therapies.
Dr. Foster, you want to comment? Dr. Vetter, your hand was up.
I just wanted to say I heard recently that when the patents expire, that there are already plans for generics to be released from India. So that would help, I think, us a lot, and I think it would be very sort of cost effective, certainly for a country like South Africa, to access those drugs. And then I also heard recently that there are some studies that are planned to look at as little as 2 cycles of pembrolizumab in advanced skin cancers that are inoperable. And they've shown that there are patients who respond to as little as 2 cycles and then go into complete remission when it comes to skin cancer. So I think it will, that becomes something that is affordable if you combine generics with lower doses and fewer cycles. And I think that will certainly be the future. And I just also wanted to ask, how many of the general American population really has access to these drugs on a completely accessible basis? Because I know that the big centers, obviously people are enrolled in studies, and it always comes across as though, this 2-3 drugs used in one patient, it becomes almost, it gives the impression that it's the norm. But surely, with my knowledge anyway of the American health system, there must be many patients who cannot access these drugs in America as well, not just in Africa and other low middle income countries. Or am I wrong?
I don't know if I know the exact percentage, Julie, but I would think that from a standard of care perspective, when you're prescribing within the label for these drugs, they're accessible to most patients, either through their private health insurance or through Medicare and Medicaid, because these drugs, it makes a difference here if the drug is FDA approved or not. So if it is FDA approved, then it's easier to get to patients, and you don't have to go through the process of pre-approval or pre-authorization. If you're prescribing, for example, I just give an example. If you're trying to give Pembro in a salivary gland tumor, right, because you did a CPS and it's 70, then you're prescribing Pembro outside the label because it's not approved for salivary ductal carcinoma or other. Then it becomes a different setting because you're not prescribing within label. Then you're likely not going to be able to prescribe the agent without getting it from either drug company or getting through a pre-authorization process. But if prescribing it for a head and neck cancer patient with a CPS that's higher than 1 or higher than 20, again, I could be wrong, but my understanding of this is that it's actually most people would have access to the drug. The problem becomes like thyroid, for example, is another example where it's hard to give immunotherapy because in thyroid is outside the label. You're prescribing it because, of what Mark is showing as, single institution or, small series that showed benefit. And then you're trying to prescribe Pembro for an anaplastic thyroid cancer patient. It's not within label. So then you have to go through a process of pre-authorization. And that can be, and with anaplastic, which is rapidly growing, that could take some time that you don't have. On the other hand, for example, the FDA recently approved the brafnib trametinib for any cancer with the BRAF V600 mutation. So now if you are in a situation where, like Mark has said, you have an anaplastic thyroid cancer, you do a quick IHC, you get it in a day or two, then right there you can give an FDA-approved agent, the brafnib trametinib, for those patients while you wait for the surgery and while you plan your surgery. So for the BRAF inhibitors now, they're more accessible because now they're within FDA label. They were not before. With Pembro and Nivo, it's still a challenge because they're not FDA approved for thyroid cancer.
Dr. Rafario, can I quickly ask you for the surgeons around the table? So out of your experience, if you're anaplastic thyroid carcinoma, how many of those patients end up during their treatment of a tracheostomy?
So for our BRAF mutated patients, it's few. Few of those end up with a tracheostomy. I'd say, less than 20% for the BRAF mutated patients, because they're able to get on these drugs and because there's such a dramatic and rapid response for the vast majority of patients. In that response, patients will start feeling that response within literally a couple of days, oftentimes. So unless a patient with a BRAF mutation comes in really acute distress, we're going to try to avoid a tracheostomy in that patient. I mean, obviously, if we need to do a tracheostomy, we'll do it. We're going to do what's safe for the patient. But if they're not in acute distress, we're going to wait and let the BRAF MEK inhibitor and immunotherapy do its work. For patients that are not BRAF mutated, obviously, a few of those patients are upfront surgically resectable. Most are not. So if they have unresectable disease, or and or significant distant disease, a higher percentage of those patients will ultimately end up with a tracheostomy, because while the drug agents that we described, the targeted therapy and immunotherapy combinations that we described are effective in some patients, they're not as uniformly effective and they're not as dramatically effective. And so some more of those patients, do end up with a tracheostomy tube. Maybe half of those patients that are BRAF wild type and are not, upfront surgically resectable. So I think it depends on largely the mutational profile of these tumors really dictates a lot in terms of their prognosis and their treatment. I think eventually, similar to how we have separate staging for HPV-associated squamous cell carcinoma, we will definitely have a different staging system for BRAF mutated anaplastic thyroid cancer, at least some type of differential staging system, because there is a dramatic difference in the with the availability of these drugs, if they're available. And I understand they may not be available in all settings at this point throughout the world, but we can only hope, as a lot of novel treatments go, I think that, hopefully these, as patents run out and stuff and such, hopefully these drugs and these effects of these drugs will filter to, the entire population of the world as well. Obviously, not a problem that we can solve in this kind of a webinar, but we do hope for that day.
Dr. Veter?
Sorry, I was swiped. No, that's an old hand. Sorry.
Is that an old hand? Thank you very much. So, I don't know if there's any other comments. So I think maybe we can wrap it up, and maybe everyone can just quickly comment before we end. I see we lost Dr. Torres home, so I hope he's okay. Dr. Kanile, if everyone can maybe just end off, I think it's time to end off. Just quickly a comment maybe for the registrars in the room.
I think I'm just going to say this was a very good webinar, and the topic that was covered is something that we deal with it so often in our clinical practice for the registrars and the fellows who are sitting for the exams. And this is what is expected of them, to have an idea around these topics. And I hope they took something from the two experts that have given us the cutting edge the data that we can use in our daily practice. I'd like to thank you guys for a good job that you have done.
I think just a final comment. When we had our annual Oncology Congress last week, we had Professor Fagan also talking about what we would call the standard of care. And I don't think we should lose heart in South Africa. I think we should take heart. We have the resources and the ability to find solutions for problems like cancer using the resources at our availability. And I think we must really try and I think especially the generic companies that are coming to the fore and really I was going to say take the lead in producing drugs at the moment in Africa, in India, and perhaps getting them to take hands with the universities and looking at finding ways to increase availability and also accessibility, and maybe looking at finding unique solutions in integrating these drugs into the management of patients with advanced cancers like head and neck cancers in resource-constrained environments. I really think we have the ability to start making a difference that can not only affect people in South Africa, but also the whole of Africa and even other low to middle income countries in Asia and the Middle East.
Yeah, well, I would just say I agree with Dr. Green. I know Professor Fagan very well. He's a good friend of mine, and I've spent time with him in Cape Town, and he spent quite a bit of time with us in the U.S. And he gives very eloquent talks on the subject of not only resources in the African continent and other settings around the world, but also innovative ways to work with those resources. So I think there is a lot of hope. I hope that by seeing what we're doing in a little bit different setting, I hope that it does sort of help to see what's out there, even if it can't be applied to every one of your patients at the moment. But I think it does provide hope for the future in terms of what we can all hope to mutually achieve for our patients, in any setting in the world.
Yeah, and maybe just to add, I mean, that was exactly what Prof. Haddad also mentioned of that study that came out now in India. I mean, they used a very low dose of nivolumab, and they showed an increase in 150 patients. They had an ECOG status of 1 to 2, and I mean, they had an increase in their first 1 year overall survival from 16% to 43%. So I mean, this is also the way I understand it as a surgeon. This is in evolution, and we new data is coming through, daily. So I think, maybe in 2, 3, 4, 5 years, we sit again and say, listen, we've got cheaper drugs, lower doses, and we can help patients. But I think the challenge at the moment we are facing it well in South Africa, private and public. So, I really appreciate all the comments. I think that was the nice thing about having representation tonight from public and from private, to just see what our challenges are, and that we do have to approach our patients, obviously according to surgical and oncological principles, to get the best outcome. Anything else anyone wants to comment before we say goodbye and end off the webinar? Anyone wants to comment? Then I think I want to just end off this webinar, and I want to really thank each and everyone again. Thank you, Professor Rafariu. Thank you, Professor Haddad. Thanks for each and every panelist. We really want to thank you. It's after hours in South Africa. It's almost 9:30. So thanks for your time. I hope this was a learning session for me as for everyone else also. And then I just want to thank again our sponsors, MSD, for sponsoring tonight, and the QR code will be available. Thanks, everyone. Have a great evening and look after yourself, Professor Haddad and Professor Rafariu. I highly appreciate it. I hope to see you guys soon. Thank you very much. Bye-bye.
Thank you so much.
Thank you. So honored to be here.
Thank you very much. Bye. And thank you, Johan, for organizing this. It was wonderful.
No, me and Mark. It's a pleasure. Take care.
Sorry,
Bye-bye.
Mark too, but I don't see him. So thank you.
Bye-bye.